Hello, Assalamualaikum and good afternoon. I'm Associate Professor Ayub from Faculty of Medicine. It's a cardiothoracic surgeon. So we start a case series first on sarcoma with primary metastasis management dilemma. Next, okay. Pulmonary metastasis in sarcoma itself associated with very poor prognosis. Even though with complete surgical resection is proven to prolong survival, management differ from cases to cases. Here are a few examples. Case 1, I have a 18 years old boy with left tibial osteosarcoma, left AKA dance, and neoadjuvant chemotherapy by orthopedic and oncology, and follow up by CT surveillance. First week of X-ray, there is no metastasis. Unfortunately, second week of X-ray, there is small nodules, and the day or one day or 2 days before the admission, we repeat the X-ray. The lesion is getting bigger, and then we proceed CT scan. Unfortunately, become unoperable already within the 3 weeks. Very unfortunate, and patient passed away 1 month later. Another case, we have 61 years old lady with recurrent atypiloid sarcoma, multiple white local excision tumor duns, single nodules of the lungs, of the left lower lobes, high-grade sarcoma. We proceed very fast urgent surgery for the patient since very sarcoma, and the treatment the only is resection. We are able to do a small surgery, small camera surgery, and even full patient still alive. No meds at the moment, within 2 years. Case 3, there's a 40 years old recurrence against a sarcoma, underwent distal right humerus and transhumerus amputation, have a multiple lung lesion planned for metastaectomy for the lung, and patient also agree. Patient went for the operation for multiple metastaectomy. Unfortunately, again, when we put the scope, not also there is a single lesion, there is a multiple lesion, and also there's severe addition to the major vessels. Unfortunately, we are unable to proceed with the surgery. We abandon the procedure. And case 4, 26 years old gentleman, same osteosarcoma, left AKA, and second. And we have had already 2 times metastaectomy on the other lungs. Planned for the third metastaectomy. However, when we do repeat CT scan, there's a lesions over the proximity of the left because it's a very difficult surgery, and patient passed away 4 months later. So, my discussion: surgical metastaectomy is mainstay treatment for sarcoma with pulmonary metastasis. Significant survival benefit with complete resections, but no consensus on metastasis size or the number of the lesion. Maybe considering patient inoperable, or maybe Prof. Chin have some immune therapy, or maybe some targeted therapy in the future for sarcoma. Conclusion: surgical metastaectomy improves patient survival, case-by-case assessment, and multidisciplinary very important, including the family members in paramount deciding the best course of the action. Thank you.
Any questions for Prof. Ayub? If not, we will proceed with the second presentation by Prof.
Okay, ambil gambar lagi. Okay. Again, I have a case of thymic, what do you call that? No, not this one. Eh. The second presentation. Peanut.
Do we have Prof's second presentation? Yes, correct.
This one? Okay, yes. So, when we're talking about the neuroendocrine tumor, as mentioned before, just now there's a lady asking about the neuroendocrine tumor unknown with a primary to the liver, and did my patient have a neuroendocrine tumor of the thymus itself? So it's very rare, part of the thymic become the neuroendocrine tumor. It's 0.18 out of thymic cancer. So the current treatment recommendation is based on very limited cases here and retrospective analysis. So I have a 60-year-old gentleman, progressive worsening of non-productive cough for 4 months, reduced effort intolerance, restlessness, and we proceed with a CT scan, and they show very large anterior mediastinal tumor surrounding the max effects. So, causing we in the doubt. That's what's the approach for this patient. So we proceed first from this is from the axial cut CT scan show a tumor, and it's for coronal view. This is about 10 times 10 centimeters, the weight about 10 kilos. So we decide to go with medium sternotomy first. We try to minimize the incision. However, unfortunately, we are unable to do the medial sternotomy. We need to extend to anterior and lateral, anterior-lateral medial thoracotomy to release the tumor. And then because we need to stand by the cardiopulmonary bypass, because and then the position need to do a semi-prone, semi right left side up, to avoid the mass effect of the heart during the operations, because a compression we can lock, can cause the BP and can cause hemodynamic unstable. We need to be very cooperative with the NS during the surgery itself. And we are very experienced anesthetists. The tumor about 10 times 10 centimeters. And this is a type of the tumor, neoplastics, to be neuroendocrine tumor. Discussions again, definitive treatment for TNET is a complete surgical resections. It's either depend on the position of the tumor, it's either medial, like for this patient, we combine median and lateral sternotomy. And the role of neoadjuvant chemo is still unknown and still debatable, and no significant survival outcome for adjuvant radiotherapy. In my conclusion, still combined approach is feasible option in large thymic neuroendocrine tumor. Adequate pre-operative planning very important, and close lies with the anesthetist and single lung ventilations to prevent paracardial injury. Thank you.